Good afternoon, everyone. We will be beginning shortly the webinar series. Kindly wait for a few minutes. Very good afternoon to all the participants. On behalf of Medical Education Unit AIIMS Bilaspur, it is my immense pleasure to welcome you all to this webinar series. And the topic for today's webinar is Competency-Oriented Medical Education, Need of the Hour by Dr. Niket Verma. I would now like to request Dr. Poonam Verma, Additional Professor, Department of Physiology and Faculty in Charge Medical Education Unit at AIIMS Bilaspur, who has been the key person in organizing this webinar, to kindly begin and moderate the session. Ma'am.
Thank you and very good afternoon to all. So today's topic of webinar is competency oriented medical education, need of R. So really it is a need of R to understand what is competency and how this can be implemented in the curriculum. So to throw a light upon on this topic, we have a very great faculty, Dr. Niket Verma. I'm sharing just this presentation.
Good afternoon, ma'am. Good afternoon, everyone.
So Dr. Niket Verma is a assistant professor in the Department of General Medicine, and he is a member of Center for Medical Education Technology at AIIMS Bhatinda. He is a Famer Fellow of 2020 batch from CMC Ludhiana and adjunct faculty for advanced course in medical college at NMC Nodal Center, CMC Ludhiana. He is also additional resource faculty in 1920 at MAMC. He is an NMC observer, or he was an NMC observer for 3 revised basic course workshop, resource faculty for at his institution for various workshop and organizing secretary for numerous CMEs and workshop at AIIMS Bhatinda, and previously he was at ACMS Delhi. He is a member of Institutional Academic Integrity Panel, Adesh University Bhatinda, member of British Journal of User Advisory Panel for South Asia. He is a faculty and judge at NCHP 2020 Dehradun and NCHP 21. He received I. Shakuntala Devi Memorial Medal for Best Innovation in Medical Education, and second prize in Dr. B. Naganana Memorial Medal, Best Faculty Research Poster in AP Medicon 2021. He has published numerous articles, authored 16 logbooks for the new CVME UG curriculum, and he's received 5 gold medals, 10 certificates of honor, and 5 certificates of merit in MBBS. So I welcome Dr. Niket, and hope you will enrich all of us with your experience in competency-based medical education. So over to you, please.
Thank you so much, ma'am. Good afternoon. I hope I am audible.
So you're not audible.
Am I audible now?
Yes, sir, you are audible.
All right, thank you. Very good afternoon, Dr. Poonam ma'am, and good afternoon to all the faculty from AIIMS Bilaspur. It's indeed a matter of honor for me
So
to
you're
be.
not audible. Dr. Niket, unmute yourself. Sir, could you unmute yourself?
Ma'am, I've already unmuted. Am I audible now?
Dr. Niket, you are not audible.
Ma'am, now? Am I audible now?
Ma'am, he's audible. Good evening, ma'am. Poonam ma'am, we can hear Dr. Niket.
Okay, I think Dr. Meenakshi, if you could just inform Dr. Poonam.
Okay, sir, I'll do that.
अच्छा तो हमें तो ऑडिबल नहीं हो रहा इधर तो नहीं आ रही हाँ
Sorry, I think that was Dr. Poonam. There is some technical issue at her end. If I see the messages, I think everyone, the participants can hear me.
Yes, now you are audible.
All right.
Please start.
Thank you. So good afternoon, everyone. Good afternoon, Poonam ma'am. Thank you so much for this opportunity to, share my thoughts about CBME with the esteemed faculty of AIIMS Bilaspur. And I'll just share my presentation. I hope this is visible to everyone.
Yes, it is visible.
All right, thank you. So the topic we are discussing today is competency-oriented medical education, need of the hour. Now, like Poonam ma'am has already mentioned, I met ma'am recently, and she was here in AIIMS Bathinda as an examiner for the exam in physiology. And ma'am was discussing that, AIIMS Bilaspur is now embarking on a journey of medical education. I'm sure with ma'am as the head of the MEU, all of you will be very well trained, or, you will be aware of all the newer changes in the curriculum. And you have a workshop which is planned in the very near future, a revised basic course workshop, a 3-day workshop. So, we thought, me and ma'am were discussing, and we thought this will be a good way to basically introduce you to CBME. We won't use the term CBME since all of you know AIIMS does not come under the NMC. So we are not actually following CBME or competency-based medical education. So we've named the session as competency-oriented medical education. And the main aim being, or the session objectives being, that we should be able to identify the key features of a competency-based educational program. And we should be able to describe the objectives of the Indian Graduate Medical Training Program. Along with that, we should be able to enumerate the roles of an IMG or an Indian medical graduate, identify the various domains of a competency, as well as discuss the advantages and challenges of a competency-oriented training program. So very quickly and in a very concise manner, we'll try and discuss what is a competency-oriented training program and how that can be beneficial for you as a faculty member. So these are the session objectives for today. Now, what has changed from previously? So let us just look at what the NMC curriculum. All of you know that this is the competency-based undergraduate curriculum, and there was a lot of noise about this in 2019, just 6 months prior to COVID, and we had this new curriculum that was introduced across the country. And this is how, when you open up the curriculum on the internet or on the NMC website, this is what you see first of all. So when you open up curriculum volume 1, volume 2, or volume 3, there are 3 volumes. This is what is the start of all these 3 volumes, which mentions the name of the curriculum as CBME. Also gives you certain terms such as knows how, shows how. So I'm sure all of you are well aware of the Miller's pyramid. Then you see certain verbs which are written here, which is enumerate, describe, observe, demonstrate. Then you have integrate. Then you have the verb communicate, interpret, collaborate, guide, correlate, critique. These are verbs which have been introduced for the first time in the CBME curriculum. If you take a closer look at the bottom 2 lines, you will see something called as a clinician, a communicator, a team leader, a professional, or a lifelong learner.
पता
And
करना
finally,
पड़ेगा
those
कि
colored
इनको भी वही
boxes
कभी
right at
भेजना
the
पड़ेगा
end.
कि उसके पैसे कौन देगा पीपीआई सीडी रिजल्ट डालने के ना
Good evening.
Request
Dr.
all the
Poojan
participants to
Logan.
please mute yourself. Please mute yourself. Okay, continue, Dr.
I
Niket.
think she's muted. Yeah. And if you look at the last line, you see these nice colorful boxes, and you'll see knowledge, skill, attitude, values, responsiveness, communication. And whenever we start, like ma'am discussed initially also, I was the observer for the revised basic course workshops at multiple colleges in New Delhi. And whenever we used to start discussing the CVME curriculum, people used to be amazed by the first page of the CVME document. So we'll just go ahead and see what all of these things mean. Now, this is called as domains of learning. So this is one of our objectives today. And these are the domains: knowledge, skill, attitude, and communication. I'm sure many of us are aware about these 4 terms. And then we have different levels in the competency. So when you open up the curriculum and you go on to the second page, you are basically introduced to the domains of learning and the levels of competency, whether it is knows how, shows how, or performs, either under supervision
First
or
you take
independently.
what I'm taking fiber.
Fiber I'm taking Abdul I'm taking
Veer
them.
Sharma sir, please,
I
if you could mute
request
your mic.
admin IT to please mute all the participants.
I did the chicken and mutton.
Requesting participants also to mute yourself, please.
Mutton I'm not taking. So any drug medicine?
Provic one is there.
Probic, no?
Okay, I think he's muted now.
Okay.
So this is what you see when we go on to domains of learning and levels of competency. Now, when we move a little further up, ahead from this, we see the topics and outcomes in various subjects. So I'll request all of you to identify your subject and see the number of outcomes that the NMC has given to each of your subjects. So, if we look at human anatomy, you have 409 outcomes. Similarly, if you look at physiology, there are 137 outcomes. So outcomes loosely is equivalent to a competency. So basically, we can assume outcome to be equal to a competency. Similarly, biochemistry, pharmac, patho. So this is the first volume of the document, and this shows you pre and paraclinical subjects. This is volume 1. When we go ahead on volume 2, these are the subjects that are covered. So you have medicine and allied subjects, all allied to general medicine. So respiratory, pediatrics, psychiatry, dermat, and PMR, which is a new subject that has been introduced for MBBS. Volume 3 is surgery and allied subjects. So you have general surgery, opthal, ENT, obs, gynae, ortho. Along with that, you have anesthesia, radio diagnosis, radiotherapy, and dentistry. Now, if you note carefully, general medicine actually has the highest number of outcomes, 506. After that, you have human anatomy, which is at 409. And then at number 3, you have pediatrics, which is at 406. So what exactly is CVME? This is the document. This is a physical document. You can keep printouts of this. But what exactly is a competency-based or a competency-oriented medical education training program? Now, remember, this is basically a model which is centered on the student. It is focused on mastery of the competencies, and it is based on something called as learning outcomes. So these are the 3 very key features of a CBME curriculum. It is student centric or focused on the student. You have to master a set of competencies. Every subject is divided into competencies, and you have to achieve certain learning outcomes which are predefined. Every subject will have to define their own learning outcomes. They can be session-based outcomes, or they can be outcomes to be achieved at the end of completing a training program. Now the question is, why are we talking about it right now? ऐसा क्या हो गया कि suddenly हर तरफ competency oriented, CVME, revised basic workshop, CISP workshop, so much discussion about it wherever you go in every forum. I'm sure many of you have given interviews recently or joined AIIMS Bilaspur recently, and many of you may have been even asked questions regarding medical education in your interviews. Why are we talking about CVME right now? Remember, we need to ask ourselves a question: are we really producing medical graduates who are competent to cater to the health needs of the society? That's a question we need to ask. And the key word here is competent. So just because someone has been taught a particular subject for 4.5 years, completed 1 year's internship, does that really make a student competent to cater to health needs of the society? And once again, I'm not saying individual, I'm not saying community, but we will refer to societal health needs in our discussion today. So remember the golden rule of medical education. We need to train learners so that they are competent to treat patients as if that patient is you. आप अगर एक मरीज हैं और आप हॉस्पिटल में एडमिटेड हैं, what kind of a doctor would you like to treat you yourself when you are the patient? That should be our aim of training the undergraduates. When you as a patient visit a doctor, what expectation do you have from the doctor? Is it only the ability to diagnose and treat? सब्जेक्ट बहुत अच्छी तरह आता है, टॉपर इन द सब्जेक्ट, नोज एवरीथिंग theoretically, academically, very very good, 200% good, or do you look for some compassion and reassurance, or do you focus on the behavior of the doctor, or do you look for all three? थोड़ा सा कॉम्पिटेंस भी ज़रूरी है, कंपैशन भी ज़रूरी है, रीएश्योर करना भी बहुत ज़रूरी है, और बिहेवियर तो अच्छा होना ही चाहिए. So I'm sure all of you will agree, since I'm not there physically in front of you, so we may not be able to interact so much, but I'm sure you'll all agree. We look for all these, criteria, and many times we are assured that all the doctors are equal in their ability to diagnose and treat. We look for a doctor who is more compassionate, who is more empathetic, who has a better behavior, who has compassion towards you, understands your problem. So I think that becomes even more important in such scenarios. So this is called as the iceberg phenomenon. What you see or what is explicit is actually covered by an iceberg, the implicit 90% part. Titanic, when it sank, ऊपर 10% सिर्फ iceberg दिखा है. आप सब जानते हैं iceberg में only 10% is visible. The rest 90% is below the surface of water, जो हमें नहीं दिखता है. तो अगर कोई अच्छा डॉक्टर है जिसमें कंपैशन है, एम्पैथी है, आपसे अच्छी तरह बात भी करता है, इट्स नॉट ओनली नॉलेज, इट ऑल्सो इंक्लूड्स एटीट्यूड, योर स्किल, कम्युनिकेशन स्किल्स, इवन योर वैल्यूज एंड रिस्पॉन्सिवनेस. ये बहुत इंपॉर्टेंट कंपोनेंट्स हैं, और आज तक इस कंपोनेंट के बारे में हम बात नहीं कर रहे थे. whenever earlier we were, it was on the whims and fancies of the faculty. We'll come to that later. So these were the implicit portions of the curriculum, many of which were not being emphasized enough, and the explicit was what was visible to the society. And over the past few years, you have seen, especially during COVID, we have seen what a large gap between the allopathic form of medicine which we practice and the society. There was such a huge gap. There was absolute, mistrust between the society and the doctors, and it has been growing over the years. And you have incidences of doctor-patient violence which are taking place. And much of that has to do with the implicit part of the curriculum, which we are not focusing enough when we are teaching our students. So how can we assure the public that our graduates are competent? After all, perception matter करता है. अगर society perceive करेगी that the doctors are competent, they will trust you more. And if they trust you more, then there will be lesser incidences of violence or, between patients and doctors. So we need to produce doctors who can deliver effective health services to the community. Now, coming to another of our learning objective for the session, the Indian Graduate Medical Training Program. What does that say? It says that the undergraduate medical education program is designed with the goal to create an IMG who possesses requisite knowledge, skills, attitudes, values, and responsiveness to function appropriately and effectively as a physician of first contact. And this is where I've highlighted with this blue arrow, physician of first contact of the community while being globally relevant. So to achieve this, there are certain goals, there are certain roles that have been defined under this program. So before we move ahead, let us reframe the question that we talked about a few slides earlier. We talked about, is the graduate competent to treat the health needs or to cater to the health needs of the society? I'm reframing the question for you. Is medical education as a system producing doctors who can be entrusted with the health and lives of our citizens? So now the key term becomes trust. Is there trust between society and the doctors? Is there trust between patients and the healthcare workers? Can we entrust the lives of our citizens to the doctors we are training today? And this brings us to the very important component, and that is the goal of the Indian Medical Graduate Program. And that goal we saw earlier here is to is to create an IMG who possesses the knowledge, skill, attitudes, values, and responsiveness to function as a physician of first contact in the community while being globally relevant. Physician of first contact or primary care physician. The aim is not to create cardiologists. The aim is not to create neurosurgeons. They are required, but they are required in tertiary and quaternary care setups. The aim is to create a physician of first contact or a primary care physician to cater to the health needs of the society. So we have to orient ourselves towards this goal when we start teaching students in the class. Tomorrow, when I go to class as a medical educationist or as a teacher, I must keep this goal in mind when I'm teaching my students. And to achieve this goal, there are certain roles that have been defined. Now, I'm sure you'll discuss this in greater detail when you have your revised basic course workshop, 3-day workshop. But these are the broad 5 roles of an IMG. And one role is clinician, of course, very important. But then there are 4 other roles. One is communicator. One is a leader and member of a healthcare team. One is a lifelong learner. And the final one is a professional. And you will have a session on professionalism also in RBCW workshop. And you will realize how important it is to inculcate professionalism in the students, apart from teaching them how to be a good clinician. So the revised curriculum or a competency-oriented curriculum tries to achieve all these roles, or pushes students or encourages students to achieve all these roles. Not only a good clinician, but a good communicator, a good leader, a good lifelong learner, and an excellent professional. So let us look at this image. And you see a road and you see a car and you see the sunset or sunrise, depending on your perception, and you see some clouds in the sky. Now, if we talk about my goal, now since again, sorry, I'm not there, physically there with all of you, otherwise we could have discussed about this. So if we talk about the goal is, let us say this is a road which leads to AIIMS Bilaspur, let us say. And it's evening time, andhera hone ke pehle, the goal is that we should reach AIIMS Bilaspur on time before it gets dark. However, that requires me to fulfill certain roles. I have to fulfill the role of a driver when I'm driving this vehicle. I have to drive my car properly and safely, follow all the traffic rules so that I can reach my destination safely. However, that's not the only thing. I should be competent enough to save myself from a pothole on the road. मान लेते हैं रास्ते में सामने गड्ढा है, उससे कैसे बचना है ये मुझे आना चाहिए. अचानक से सामने if there is an animal crossing the road, I must know how to brake. I must know how to increase my speed. If it is a hilly road, I must know that I should drive only on gear 1. So there are certain competencies that are required for me to fulfill my role of a driver. And this similar thing can be, extrapolated to an Indian medical graduate or our graduate training program. So another session objective that we had today, difference between competency, competent, and competence. So if I can have any volunteer who wishes to clarify the meaning of these 3 before I go ahead. What is the difference between these 3 very important terms? Competency, competent, and competence. They're all there on the screen in front of you. Anyone who volunteers to answer?
Please raise your hand, or you can type in chat box also. Those who want to answer.
Just to make it slightly more interactive, it will be good to have your feedback.
Good.
Anyone who can differentiate the 3, competency versus competent versus competence?
These are not technical terms. These are just English terms.
And this is not an exam. This is not a prof exam. You are free to answer. We are not marking you. मैम आपको ही किसी को अपने आप वॉलंटियर करवाना पड़ेगा. Anyone from your college?
Consider skills to be learned.
Yeah. Please unmute yourself and speak out. Yes, Dr. Vipin Abi. No one is ready.
Okay, Dr. Deepan has typed something. Competency is a skill to be learned. Individual who learned competencies is competent. Okay, that's a good way of putting it. So the particular skill जो हमें सीखनी है, that is a competency. और जिसने वो skill सीख लिया है, that is competent. Okay. Now just to add on to what Dr. Deepan has written, I'll put forth another question. मान लेते हैं हमने 5 साल का ट्रेनिंग प्रोग्राम कंप्लीट कर दिया. आपके यहाँ पे बिलासपुर में एमबीबीएस स्टूडेंट्स हैं. लेट अस से यू आर टीचिंग देम ऑल कॉम्पिटेंसीज राइट फ्रॉम एनाटमी, फिजियो, बायोकेम, पैथ, फार्मा, माइक्रो, फोरेंसिक मेडिसिन, ईएनटी, ऑप्थेल, कम्युनिटी मेडिसिन, मेडिसिन सर्जरी, गायनी, पीडियाट्रिक्स, everything is covered. And then the student has completed 1 year's internship. Is the student prepared to, face every possible medical scenario, every medical emergency? Are we training पूरी medical science क्या हम complete कर सकते हैं 5 साल में? How do you define कहाँ पे वो limit होनी है competent की, जिसके बाद you have to pass the student and the rest is to be learnt later on? How do you define that cutoff?
Means we should, how can we ensure that our student is competent enough to face the real life situation?
रियल लाइफ सिचुएशंस. एंड कहाँ से डिसाइड करें कि हाँ 50% चीज़ें हमने सिखा दी, इतना काफ़ी है कॉम्पिटेंट करने के लिए. जब ड्राइविंग सीखते हैं, लेट अस से सम पीपल गो टू ड्राइविंग स्कूल, सम पीपल लर्न फ्रॉम देयर पेरेंट्स, सम पीपल लर्न फ्रॉम देयर फ्रेंड्स, सम पीपल लर्न फ्रॉम नोवेयर, दे स्ट्रेट अवे स्टार्ट ड्राइविंग. सो ये कैसे डिसाइड होता है कि अब ये गाड़ी चलाने के लिए कॉम्पिटेंट हैं? आई मीन देयर हैज़ टू बी सम सेट ऑफ रूल्स और सम ब्रॉड फ्रेमवर्क जिसमें यू हैव टू tick mark everything that okay, this person is now competent, and you can entrust the lives of your citizens to this Indian medical graduate. Anyone who wants to volunteer and answer this?
Yes.
Is it just that they have passed the prof exams? Is it okay? Is it enough? काफ़ी है उतना, या उसके बियॉन्ड हमें जाना है? जिस एग्जाम में एग्जामिनर ने उठ के हिस्ट्री सुनी ही नहीं, सिर्फ वार्ड के पास एक कमरे में बैठ के जो भी स्टूडेंट ने बताया वो सुन के मार्क्स लगा दिए. or maybe many times we all go and take exams. Sometimes it is lunch time and sometimes we have to leave for home because train निकल जाएगी and flight का time है, whatever. So the last 5 students are brought in together और हम पांचों का एक साथ वाइवा लेते हैं and then we mark them quickly.
एग्जामिनर्स को घूमने जाना है.
घूमने जाना है. So is that really a fair assessment of? और एक बार पास हो गए तो competent हो गए, एक बार प्रोफेशनल एग्जाम हो गया तो हो गया, then you are competent. लोगों की जान आपके हाथ में है. So Dr. Sumita has mentioned students should be able to demonstrate the learned skill in real life situation. All right, so I'll quickly show you what I mean by these 3 terms. A competency, number 1. So if you know about the basics of driving, can you accelerate and brake smoothly? Can you approach a red light and turn, or can you take a U-turn? Can you turn left? Can you turn right? These are individual competencies जो हम टारगेट कर रहे हैं जब आप ड्राइविंग स्कूल में हैं. लेट अस टेक द एग्जांपल ऑफ ड्राइविंग. आप कॉम्पिटेंट है, मतलब आपको सरकार ने एक बार लाइसेंस दे दिया है. सो इफ द स्टूडेंट हैज रिसीव्ड MBBS डिग्री, द स्टूडेंट इज कॉम्पिटेंट एज पर द गवर्नमेंट, एज पर योर इंस्टीट्यूशन, द स्टूडेंट इज कॉम्पिटेंट. बट डज दैट रियली मीन कि हर पॉसिबल मेडिकल सिनेरियो वो डायग्नोज और ट्रीट कर सकते हैं? नो, दैट इज नॉट ट्रू. सो दैट रिक्वायर्स कॉम्पिटेंस. सिर्फ मैंने दिल्ली में गाड़ी चलाना सीखा, आई मे नॉट बी एबल टू ड्राइव प्रॉपर्ली ऑन अ हिली रोड, लेट अस से व्हेन आई एम रीचिंग एम्स बिलासपुर. For those of you who have learned driving only in smaller towns or villages, maybe Delhi traffic will overwhelm you. इतनी गाड़ियां हर तरफ से लेफ्ट एंड राइट आ रही हैं, आपको बिल्कुल 5-6 दिन, हफ्ता 10 दिन लगेगा ओरिएंट होने में. सिमिलरली जब ये स्टूडेंट्स आते हैं एकदम इंटर्नशिप में या इंटर्नशिप के बाद सीधा पीजी में, मेनी टाइम्स दे आर डूइंग पोस्ट ग्रेजुएशन इन सब्जेक्ट्स जिनकी कॉम्पिटेंसी कभी कवर ही नहीं हुई एमबीबीएस में. एनेस्थीसिया में पोस्टिंग में वो गए नहीं, डरमैट में उन्होंने जाके 4 या 5 क्लासेस अटेंड करी, रेडियोथेरेपी, रेडियो डायग्नोसिस, दे वर हार्डली बीइंग कवर्ड व्हेन वी वर इन एमबीबीएस. And suddenly you were thrusted into a postgraduate training program and you were expected to know everything from day one. So these are things that the student has to learn while on the job, and this is where we talked about that role of a lifelong learner. अगर आप लाइफलॉन्ग लर्निंग स्किल्स इनकलकेट कर रहे हैं बहुत अच्छी तरह से स्टूडेंट्स में, तो वो आगे जाके जब भी ऐसा नया सिचुएशन आएगा, द स्टूडेंट विल बी एबल टू लर्न न्यू स्किल्स. For example, COVID, this was a new thing. It's a new disease, a new pandemic. We had no idea how to treat it. But the lifelong learners quickly started seeing, what is working, what is not working. And then finally, we had a treatment protocol. So this is a basic difference which you should know before you go into your revised basic workshop, which is coming up in the very near future. The difference between competency, competent, and competence. Just because you're competent does not mean you have the competence to deal with every emergency situation. You may have the competence to deal with regular situations, but you may not have the competence to deal with every situation. So competency is an observable ability of a health professional, and it is integrating multiple components such as knowledge, skill, values, attitudes, everything. Competent, the word is, it just means you are certified to do certain things. So you have demonstrated the required qualities in a certification exam, and you have passed that exam and you have received a degree. That makes you certified. Whereas competence, it is more than the mere possession of knowledge, skill, and attitudes. You should be able to apply these abilities in a clinical environment to achieve optimal results. उस समय एक कॉम्पिटेंस होता है, थिंकिंग ऑन द जॉब. Quickly in an emergency room, you have to think quickly. You don't have time to open up books and read what was taught to you in first or second prof. So that is also a competence. One other competence is being confident enough when you're treating, not doubting yourself, or another confidence is you should be able to know the doses of the drugs immediately when you are prescribing them to a patient. So these are all competences where you can apply these abilities in a real life clinical environment. I hope I've slightly clarified the difference between all three. So in simpler terms, when we look at the societal health needs, competence kya hai? What society expects from a doctor. और कॉम्पिटेंसी एट्रीब्यूट्स हैं जो आपको उस लायक बनाएंगे दैट सोसाइटी कैन ट्रस्ट यू. सो यू शुड बी एबल टू मीट द एक्सपेक्टेशन ऑफ सोसाइटी एंड एड्रेस द हेल्थ केयर नीड्स ऑफ द सोसाइटी. दोज आर कॉम्पिटेंसीज, दे आर एट्रीब्यूट्स. So the strategy we should adopt as medical teachers is identify the areas which in which students should be competent or should have competence, and train the students in that direction. Many times when we are taking classes, it's the same PPT that has been made 10 years back, or we have downloaded from the internet. Whether it is actually relevant to societal health needs, we do not know. Whether it is actually required by MBBS students, we do not know. पिछले साल भी यही पढ़ाया था, इस साल भी यही पढ़ाएंगे, अगले साल भी वही पढ़ाएंगे, and year by year the same thing continues. There is absolutely no upgradation in the knowledge and skills which is taking place. There is no change which is taking place, and the same thing carries on without any change. What are the domains of competency? Another SLO that we were targeting today. So the domains are knowledge, skills, attitude, and communication. So communication also is a part of skill, but the document mentions it as a separate domain. So KSAC, knowledge, skills, attitudes, and communication. These are the 4 domains of a competency, and this is what makes up a competent Indian medical graduate. Requisite knowledge, requisite skills, requisite attitude, and good communication skills. सो ये लैडर है कॉम्पिटेंस का, जिसमें हमें स्टूडेंट्स को धीरे धीरे एनकरेज करना है आगे चलने के लिए. फ्रॉम अनकॉन्शियस इनकॉम्पिटेंस, जब नए स्टूडेंट आते हैं फर्स्ट ईयर में, उनको पता ही नहीं है कि आउटकम क्या होना चाहिए इंडियन मेडिकल ग्रेजुएट ट्रेनिंग प्रोग्राम का. सो दे डोंट नो, दे डोंट हैव एनी कॉम्पिटेंस, एंड दे आर नॉट अवेयर ऑफ व्हाट आर द थिंग्स दैट रिक्वायर देयर कॉम्पिटेंस. As we progress through the various professional years, the students are expected to become consciously incompetent. So they are aware कि हाँ, ये हमारे SLOs हमें अचीव करने हैं, स्पेसिफिक लर्निंग ऑब्जेक्टिव्स, और हमें धीरे धीरे पढ़ने पर प्रॉपर ट्रेनिंग से we'll become competent. Then they become consciously competent, which we call as perform under supervision. So जो लास्ट है मिलर्स पिरामिड में, परफॉर्म्स फर्स्ट इज अंडर सुपरविजन, देन इज इंडिपेंडेंटली. कॉन्शियसली कॉम्पिटेंट हो चुके हैं, आपके सामने कर सकते हैं सर्जरी भी, या पेशेंट को डायग्नोज भी, या प्रॉपर प्रिस्क्रिप्शन राइटिंग भी, हीमोग्लोबिन का मेजरमेंट भी, ऑल दोज बायोकेमिकल टेस्ट भी, लेकिन अभी सुपरविजन चाहिए. एंड फाइनली द लास्ट स्टेप इज अनकॉन्शियस कॉम्पिटेंस. They are competent, and now it's at a spinal level. So you don't need to constantly supervise them. They are now your postgraduate students. They know everything that has to be done. They can manage almost 90% of the regular things. बहुत कभी कभी you need to be present there when something is out of the blue and the students can't manage it. So this is the ladder on which the students have to climb, from unconscious incompetence to conscious incompetence, conscious competence, and finally unconscious competence. It's slightly confusing, but you can look at the recording later on, take a screenshot of this slide. It will be very, very clear later on. So now let us redefine CVME. So CVME now becomes an outcomes based education methodology. Focus outcomes पे है, competencies पे है, जो आपको दिखानी है, observable abilities. So you should demonstrate this competency as opposed to assuming competency. हमारे टाइम पे अज्यूम किया जाता था कि 4 साल आपने MBBS कर ली, 4.5 साल, you are assumed to be competent, you are assumed to be a good doctor. So the course delivery now has to be reoriented. You must give a chance to the students to demonstrate their competency to you rather than assuming that they are automatically competent. So how is it different from previous system? We've discussed few things. One is focuses on outcomes. The second is emphasis is on the abilities. The third is there is a de-emphasis on time-based training. ये करंटली अभी नए सीबीएमई में नहीं हो रहा है. फ्यूचर में ये मतलब एक आइडियल फ्यूचर में दिस इज देयर कि टाइम बेस्ड ट्रेनिंग से हम दूर हो जाएंगे. इट विल बिकम फ्लेक्सिबल लाइक यू हैव इन मेनी वेस्टर्न कंट्रीज. सो स्टूडेंट्स हु आर एबल टू अचीव देयर कॉम्पिटेंसीज फास्टर विल बी अलाउड टू कंप्लीट देयर कोर्स स्लाइटली अर्लियर देन देयर काउंटरपार्ट्स, whereas those who require time will be given the chance to achieve all competencies with ease as their time permits, as is feasible for them, and complete maybe not in 5 years, maybe in 6 or 7 years also, but this is not currently being done. And finally you have promotion of learner centeredness. Iski baat abhi hum karenge. So if you look at this, from teacher centered we are moving to a student centered curriculum. From content based, मेरा ये syllabus है, ये है, मुझे हैरिसन पूरी पढ़ानी है. फ्रॉम कंटेंट बेस्ड वी आर गोइंग टू आउटकम बेस्ड. क्या इस बीमारी का इलाज ये स्टूडेंट कर सकता है? दैट इज अ क्वेश्चन आई हैव टू आस्क. Similarly, from discipline based, where we are just divided among various subjects, we are becoming very integrated. All of us are together. Spiral integration. From knowledge acquisition to knowledge application. सिर्फ हमने याद करके रोट लर्निंग से एग्जाम में आंसर लिख दिए. As opposed to that, we are moving to a application of knowledge. Actually करके demonstrate करके दिखाना. From a theory based to a problem based or a case based learning. And from summative assessment or end of professional assessment to a formative everyday 360-degree assessment. Not only by the teacher, but also by the peers, also by the residents, also by the nursing staff, also by the allied healthcare staff, everyone, and on a very daily or a regular basis. So CBME starts with the requirement of the society, not from the curriculum. We go backwards. What are the health needs of the system? And then we see what, how the curriculum should be made. So from content, we are moving to outcomes. You are not measuring the input. You are not measuring the process. You are measuring the output. That is the outcome. So content बाद में बनेगा, process बाद में सोचेंगे, पहले हमें outcomes पता होने चाहिए. That during at graduation, this is what the student should be able to achieve. So students need to demonstrate what they have learned. And remember, it is not what you are teaching, it is what the students are learning that will define how quickly your program is progressing. We talked about de-emphasis on time-based training. So we'll just talk about one word, that is the tea bag model of medical education. So हम एक कप गर्म पानी में एक टी बैग डाल देते हैं एंड अपने आप 2 या 3 मिनट बाद पानी का रंग डार्क ब्राउन हो जाता है. सो इट इज अज्यूम्ड कि टी बैग की तरह हमने क्योंकि गर्म पानी में टी बैग डाल दिया है, ऑटोमेटिकली डिफ्यूज हो गई है सारी नॉलेज और सारे स्टूडेंट्स इक्वली समझ चुके हैं वट एवर वी वर ट्राइंग टू टीच. Okay, so leaving students in a particular contest for long enough, when we joined MBBS, everyone used to tell us, जाके वहाँ सीनियर्स के साथ काम करते रहो, उनके साथ बैठे रहो, अपने आप समझ में आ जाएगा कैसे करना है, अपने आप सीख जाओगे कैसे होता है, अपने आप सीख जाओगे प्रिस्क्रिप्शन कैसे लिखनी है, अपने आप सब कुछ आ जाएगा. So we are now moving away from this tea bag model of medical education. Now students will have to learn on their own pace, अपने स्पीड के हिसाब से जैसा वो सीखना चाहें, and progress to the next level only when they have demonstrated a competency. So there is no hurry or there is no force on the students कि आपने 6 months में करना ही करना है, 1 साल में finish करना ही करना है. Gradually we might move towards that system. The student is now the center of the universe of the CVME or the competency oriented curriculum. Remember, students cannot absorb all the information in a lecture. And हम चाहते हैं सारे students learn करें, not only 1 or 2 good students. So we need to make the students actively involved in the classroom to think and learn. And from that, you need to encourage the collaborative process of learning, small group teaching learning methods, where you can give individual attention, which engage the learners. They learn how to solve real life problems. And वो अपने हिसाब से अपने concept बनाते हैं, अपनी understanding लाते हैं. So this is the teaching model. On the right side, as you can see, a smaller group. This is a jigsaw class which is taking place. I conduct jigsaws very frequently for many topics in general medicine. And this is a session which is jointly designed by students and faculty. I ask my students, which is the topic you want to learn as a jigsaw? It is collaborative learning. There is democratization of learning because हर student सीखता है. A teacher is only a facilitator. You are not, giving a lecture and forcing everyone to listen to you. You are only facilitating the learning process. नॉलेज की एप्लीकेशन सिखाई जा रही है, रियल लाइफ स्किल्स सिखाई जा रही हैं, एंड स्टूडेंट्स को लाइफ लॉन्ग लर्निंग के लिए आप प्रिपेयर कर रहे हैं. As you see, when we move from passive to active learning, if in the learning pyramid, the retention rate moves from 5% of a lecture to almost 50% in a group discussion and 75% with actual practice. And if you look at teaching others, जो जिक्सॉ में और स्नोबॉल में कराया जाता है, my students, they will teach their peer group. We almost reach 90% retention rate. Look at the difference between a lecture and a collaborative small group teaching learning process. So remember, we need to focus on knowledge application and skill acquisition, and we have to move up this pyramid gradually from factual knowledge to concept building to performing under supervision and finally to performing independently. So these are the key principles of a competency oriented program. Active learning, self-directed learning. My students, they are, I tell them this is our, these are the competencies we need to achieve. आपकी कितनी knowledge है इसके बारे में? आप इसकी फिजियोलॉजी पढ़ चुके हैं, फार्मेक पढ़ चुके हैं, पैथोलॉजी हो गई है पहले. अब अगर पेशेंट को रियल लाइफ में ट्रीट करना है, आइडेंटिफाई योर ओन लर्निंग नीड्स, आइडेंटिफाई योर ओन गैप्स इन नॉलेज, इन गैप्स इन स्किल्स. Come back to me after 1 week. Then we will decide the specific learning objectives for the session that we will conduct. Take their feedback regularly. Help them to acquire skills. Learning must be relevant, must have clinical relevance. We talk about the adult learning principles. जो चीज़ relevant होगी, day to day काम में relevance दिखेगा students को, उसको वो जल्दी सीखेंगे. एंड फाइनली एक प्रॉब्लम पे फोकस होना चाहिए, उससे मोटिवेशन मिलता है स्टूडेंट्स को लर्न करने के लिए. यू गिव देम अ चैलेंज, यू गिव देम अ केस, अ पेशेंट ऑफ हैविंग जॉन्डिस और अ पेशेंट ऑफ अनीमिया, एंड देन टेल देम टू गो बैक एंड रीड फ्रॉम द सेंट्रल लाइब्रेरी द बुक्स, द ई रिसोर्सेज दे हैव, फाइंड आउट द आंसर्स, prepare a small presentation and then present in front of the class. Look how much the students will be involved in that particular class, how much the students will learn from that class. Take online feedback at the end of such sessions. You will be amazed by the support you will get from the students for such sessions. Artificial divide, pre और para clinical disciplines versus clinical disciplines अब खत्म हो रहा है धीरे धीरे. Integration has to be encouraged right from day one. This integrated model is like a jigsaw puzzle. सारे subjects मिलके jigsaw complete करेंगे. ऐसा नहीं है कि हम अलग अलग puzzles हैं, अपनी complete कर दी, उसके बाद छोड़ दिया. It's not like that. We are all part of the same system. Formative assessment is being encouraged. So this is the very easy difference between the two. Formative is when the cook tastes the soup. खाना बनाते हुए उसको रस्ते में बनाने के समय बीच में टेस्ट करना, नमक कम है, needs more salt. That is formative assessment. Summative is जब खाना बन गया आपने कस्टमर को दे दिया, अब अगर नमक ज़्यादा था या कम था, whatever it is, you can't do anything. Formative में एक फायदा है that during this cooking process you can change the content of salt or the spices or whatever and produce a good dish. Same stands true for the students. Waiting for that one day कि एक वो professional exam के पहले एक pre-prof लेंगे उसके बाद बस सीधा prof exam, that is not a good thing. Take regular assessments. If you feel the students need help, mentor the students and give them chance and time for course correction. So, we'll be wrapping up very quickly, but these are the advantages of a competency-oriented program. The students become capable of facing the real world. The learner is a driving force. It is less time-oriented and more outcome-oriented. And students achieve competencies before moving on to the next level. There is integration of learning, and the students or the health, medical profession is regaining trust of the society. Of course, there are challenges, and I know all the faculty will raise their hands when we talk of challenges. There is a massive fear of transition. It is resource intense, I agree. Initially, there is a requirement of more faculty numbers. You have to create, design specific learning objectives, design teaching learning, methodologies. You have to design the entire curriculum in a different way. But एक बार आप करके देखिए, once this has been done, every year it becomes easier for you. I get this question many times from faculty. What is in it for us? हमारे लिए क्यों ये, why is it good for me? Why should I, as a faculty of AIIMS Bilaspur, change my subject to a more competency-oriented training? मेरे लिए एज डॉक्टर निकेत वर्मा क्या फायदा है जनरल मेडिसिन को कॉम्पिटेंसी ओरिएंटेड पढ़ाने से? मैं भी 1 घंटे का लेक्चर लेके आधे घंटे में खत्म करूं, अटेंडेंस लूं, घर वापस जाऊं. लेकिन आगे चल के हम सब ने कभी ना कभी पेशेंट बनना है, और आज हमारे स्टूडेंट्स शायद आगे चल के हमारे डॉक्टर बनेंगे. Remember, you are not immune. If you are not training your students properly, If they are not able to meet healthcare needs of the society, उस society में आप भी आते हैं, आपके relatives, आपके friends, आपके near and dear ones भी आते हैं. And it gives me immense satisfaction when I see that my students have actually learned something. There has been some outcome from my session. They are not sleeping at the back of the class or attending only for the attendance part. कि सिर्फ अटेंडेंस पूरी हो गई, बस किसी तरह आके क्लास पूरी करो, फिर आगे देखा जाएगा क्या करना है. इनिशियली चैलेंजिंग है, फैकल्टी नंबर्स किसी भी कॉलेज में कम है, कहीं पे भी इतने नहीं है कि हम ऐसे एक्सपेक्ट करें कि स्मॉल ग्रुप लर्निंग के लिए यू विल हैव 50 फैकल्टी मेंबर्स इन एनी डिपार्टमेंट. दैट इज नॉट प्रेजेंट एनीवेयर, नॉट इन माय इंस्टीट्यूशन, नॉट इन योर इंस्टीट्यूशन, नॉट इवन इन द बेस्ट कॉलेजेस ऑफ दिल्ली. We are all struggling, we all have our challenges, but we have to find innovative solutions. There are small group teaching learning methods. I have published so many articles about them where I have conducted classes of 200 students alone in a small group method. And students are, एक बार वो process शुरू हो जाए like a snowball, वो automatically आगे चलता है. So multiple roles टीचर के हैं, एडमिनिस्ट्रेटिव रोल्स भी हैं आपके, क्लिनिकल रोल्स भी हैं, आपको पीजीज को भी पढ़ाना है, लेकिन यूजीज के लिए भी आपको टाइम निकालना जरूरी है. इट इज यू आर अ मेडिकल फैकल्टी एंड दिस इज योर प्राइमरी जॉब. इंफ्रास्ट्रक्चर की कमी हर जगह से, एवरीवन टेल्स मी इंफ्रास्ट्रक्चर कहाँ से लाएं, स्किल्स कैसे सिखाएं. स्किल लैब हमारे पास नहीं है. स्किल लैब पहले भी नहीं थी, आज से 100 साल पहले भी नहीं थी, फिर भी लोग स्किल सीख रहे थे. अगेन इनोवेटिव सॉल्यूशंस हैव टू बी डिजाइंड. द बेस्ट थिंग वी हैव टुडे इज द इंटरनेट. ड्यूरिंग कोविड वी वर एबल टू टेक विद इन 1 वीक हम लोग सब शिफ्ट हो गए थे टुवर्ड्स ऑनलाइन टीचिंग लर्निंग. सडनली सबको गूगल क्लासरूम आ गया था, माइक्रोसॉफ्ट टीम्स यूज करना आ गया था. ऐसे ही इसी तरह से वी कैन स्टार्ट इंक्लूडिंग इनोवेटिव सॉल्यूशंस. Even if you don't have something, maybe different AIIMS can have a collaboration. We can have students visiting each other's institution. जहाँ जो जिसका एक strong point है वहाँ से students learn कर सकते हैं. E-learning हो सकती है, आपके पास शायद कोई trained faculty है, वो हमारे students को पढ़ा सकते हैं, and vice versa. And similarly, there is a blurring of lines between formative and summative assessment. अब next आ रहा है आगे, obviously वो एक major assessment है, उसके लिए students को हमें तैयार करना है. ये कहना हमेशा कि एम्स एनएमसी के अंडर नहीं आता है एंड वी डू नॉट फॉलो सीवीएमई, दैट डज नॉट होल्ड ट्रू. थिंक अबाउट योर स्टूडेंट्स, दे हैव टू अपीयर इन द नेक्स्ट एग्जाम, एंड फॉर नेक्स्ट एग्जाम स्टूडेंट्स ऑफ ऑल अदर एनएमसी कॉलेजेस विल बी कमिंग फ्रॉम अ सीवीएमई सिस्टम. So our students also have to be oriented towards competency based system. So the path may be difficult, बट रिमेंबर देयर शुड बी फ्लेक्सिबिलिटी, क्योंकि सबने एक ही जगह पहुंचना है. गोल सबका वही है, कॉम्पिटेंट इंडियन मेडिकल ग्रेजुएट. कैसे पहुंचते हैं, आपको ज़्यादा टाइम लगता है, किसी को कम टाइम लगता है, कोई पर्टिकुलर प्रेफरेंस है मेरा जिक्सॉ पढ़ाने के लिए, आपका स्नोबॉल से, किसी का केस बेस्ड लर्निंग से, दैट डज नॉट मैटर. एज लॉन्ग एज वी आर रीचिंग द अल्टीमेट एम, द अल्टीमेट गोल, इट डजंट मैटर. द पाथ शुड बी फ्लेक्सिबल, द स्पीड शुड बी फ्लेक्सिबल, वी शुड रीच द सेम गोल. Remember, I'll just wind up in one more slide. A very famous philosopher, Confucius, once said, I hear and I forget. I see and I remember. I do and I understand. This is very essential for you to memorize every day before you go for your classes. आपका lecture student सुनेगा और भूल जाएगा. आपको कोई स्किल डेमोन्स्ट्रेट करते हुए देखेगा तो उसे याद रखेगा, लेकिन समझ उसे तभी आएगा जब स्टूडेंट उसे खुद करके देखेगा उस स्किल को. अगर हम सिर्फ दूर से दिखाएंगे कि ऑस्कल्टेट कैसे करना है, स्टूडेंट को शायद याद रहेंगे स्टेप्स, लेकिन वो उसे शायद समझ ना पाए पूरी तरह से. सो अनलेस एंड अनटिल यू अलाउ द स्टूडेंट्स टू एक्चुअली practice the skills, they will never be able to understand. And this is the crux of our competency oriented program. So this is the dawn of a new era in medicine. CVME इंट्रोड्यूस होते ही कोविड आ गया. कोविड आने के बाद देयर वाज अ लॉट ऑफ चैलेंजेस टुवर्ड्स CVME इम्प्लीमेंटेशन, बट वी आर स्टिल मूविंग अहेड. ऑल कॉलेजेस आर मूविंग अहेड. इंडिविजुअली एटलीस्ट अगर इंस्टीट्यूशन लेवल से ना हो तो इंडिविजुअली अपने डिपार्टमेंट्स में हम शुरू कर सकते हैं. ग्रेजुअली जैसे ही बाकी डिपार्टमेंट्स देखेंगे कि इसका फायदा हो रहा है, स्टूडेंट्स का फीडबैक बहुत अच्छा आ रहा है. I enjoy Dr. Poonam ma'am's classes because मैम हमेशा स्मॉल ग्रुप टीचिंग में, केस बेस्ड लर्निंग में, प्रॉब्लम बेस्ड लर्निंग में कराते हैं. सबको बाकियों को लगेगा अरे हमें भी ऐसा बनना है ताकि हमारा फीडबैक भी अच्छा है. सो एक वन पर्सन स्टार्ट्स चेंजिंग, ऑल द अदर्स विल फॉलो. So this is a new era in medicine. There are lots of changes ahead. There are lots of challenges, but I think together and under the guidance of excellent MU faculty, especially Dr. Poonam ma'am, I'm sure the path will be very easy for you. So I'll wind up here. I thank all of you for a patient hearing, and I'm open to any queries or questions, please.
Thank you, Dr. Niket. You have explained your topic in a very interesting and motivating manner. Really,
Thank you,
it is a good. It was a good session, एंड जो कि कॉम्पिटेंसी लगता है एक बहुत बड़ा चीज है क्या है, सो यू हैव सिंप्लीफाइड इट वेरी ब्यूटिफुली. सो ऑडियंस, एनी क्वेश्चन?
Any queries, any challenges you want to discuss, I'll be happy to discuss with you. We still have 5 or 10 minutes, I think.
Yeah. Anything that you want to ask, how to do it? Because here, what I think that since means in AIIMS, there is a very much requirement of faculty sensitization, faculty training to implement all these things, because faculty are new, they are not, they have means very few faculty are exposed to these medical technology. So there is very much requirement of this.
So, I mean, one more thing I would like to add from, especially from many clinical departments, many people have a lot of doubts about the whole competency oriented thing कि इसका, और वैसे भी even from any department कि हम भी तो अच्छे student थे, हम भी तो एम्स में पढ़ा रहे हैं, हम में क्या गलती है, why should we change? We should not resist change, change is the order of the universe.
Yeah.
Day to day, daily universe change हो रहा है, and we should be open to change. And this is beneficial for students. It's beneficial for you also. As a medical faculty, immense satisfaction you will achieve if you implement a competency-oriented program. So, any comments from anyone? I'll be happy to answer, please.
Any comments, please?
No, I think people are now waiting for the 3-day revised basic workshop. I hope there is some sensitization at least, ताकि वहाँ जब terms discuss हो तो कुछ तो
Yes, that is why I have planned this basic course workshop. That is more or less based on the means the program that is given by the NMC.
NMC, yes, ma'am.
But some of the topics, they are different from that of NMC. So I think after attending this workshop, our faculty will be definitely benefited, and they will be into this thing. And I would like to tell ki Dr. Niket Verma is also one of the faculty in this workshop. So Dr. Niket has accepted the invitation, and means so he'll be able to take your sessions.
Ma'am, I'm really honored you've given me this chance. Thank you so much.
Yeah. So I think if there is no query, so we can wind up.
Yes, ma'am.
Okay. So once again, thank you, Dr. Niket, for enlightening us about this very important topic, which is really a need of our. So thank you.
Thank you so much, ma'am. Thank you so much.
Thank you.
And I look forward to meeting everyone very soon for the 3-day workshop as well.
Yeah. Okay. Thank you.
Thank you so much, ma'am. Thank you.